Did you know there's a common skin tumor in horses that doesn't spread through the body, yet it's notoriously aggressive, really hard to get rid of, and can actually pop up again years after you thought it was gone?
It's a strange one, isn't it? Medically, we might call it benign, but its behavior, well, that's often anything but benign.
It really is. Welcome to the deep dive. This is where we take a complex topic, wade through all the research, and pull out the most important nuggets for you.
Exactly. And today we're diving into equine sarcoids. They're actually the most common skin tumor affecting horses, donkeys, mules worldwide.
Yeah, and we've gathered a lot of material for this, detailed vet reviews, some really cutting-edge research papers.
Our goal really is to give you a solid, clear understanding. What are these things? Why are they such a pain to deal with?
And how are they diagnosed?
Yeah.
What are the treatments? We'll cover everything from, standard surgery to some genuinely exciting new immunotherapies.
So hopefully you'll have some aha moments and get a much clearer picture of this often frustrating condition.
Okay, let's get into it then. What exactly are equine sarcoids? Like at a basic level.
Okay, so the technical definition is a dermal fibroblast neoplasm with a minor epidermal component.
Right. Break that down for us a bit.
Sure. So neoplasm just means an abnormal growth, a tumor. And fibroblasts, they're just the common cells making up connective tissue in the skin.
Wow.
So basically, it's an abnormal growth of these skin connective tissue cells.
Okay, and what's the really crucial thing we need to understand about how they behave?
The crucial part is that they are locally aggressive. They invade and destroy the tissue right next to them, quite aggressively sometimes. And they have a really high tendency to recur, to come back after treatment.
Right. Recurrence is a big theme here.
Huge. But, and this is really important, they do not metastasize. They won't spread to internal organs, like lungs or liver, the way some other cancers do.
Ah, okay, so that's why they're technically called benign, even though they sound pretty nasty locally.
Exactly. Benign because no metastasis.
Huh?
But that local invasion, it can cause serious problems, especially if a sarcoid is near an eye or a joint or somewhere delicate. It really highlights why getting onto them early and decisively is often so important.
That makes sense. And you said they're the most common neoplasm.
Yeah, the most common in horses. Reports vary, but maybe 1 to 12% prevalence. And they account for a big chunk, 15 to 65% of all equine neoplasms.
Wow. And found everywhere. No specific hotspots.
Pretty much global, no real seasonal thing, no specific geographic preference.
Who's most at risk? Any particular age?
They can affect any age, really, but most often diagnosed in younger adults. Typically between 3 and 9 years old seems to be the peak time.
Sex, male or female?
No strong gender link overall, though interestingly some studies hint geldings might be at slightly higher risk. Needs more research, though.
And what about breeds? Are some more prone than others?
Yes, definitely. We see a higher risk in quarter horses, maybe also Appalisas, Arabians, thoroughbreds.
Any breeds less likely to get them?
Standardbreds actually seem to have a lower risk, which is interesting.
That variation between breeds really suggests genetics must be playing a role, right?
Absolutely. Genetic susceptibility is strongly suspected. The thinking is it's probably a polygenic inheritance pattern, multiple genes involved.
Oh, okay.
Yeah, we see links to specific immune system genes, things like MHC class I, ALA-A3, for example, and MHC class II, like ELA-W13. Also some non-MHC genes on chromosomes 20 and 22.
So it's tied into the horse's immune response.
It seems that way. How the horse's body is genetically programmed to react or not react seems to be part of the puzzle. And primarily these affect the skin, of course.
Okay, let's tackle the etiology puzzle then, because it sounds like it's not just one simple cause like a single virus. We hear bovine papillomavirus, BPV, mentioned a lot though.
That's right. There's a consistent, very strong association between equine sarcoids and BPV, mainly BPV1 and BPV2, also BPV13, and some variants that seem more horse-specific.
And you find the virus DNA right in the sarcoid cells.
Yes. BPV DNA is detected in the nuclei of the fibroblast cells in most sarcoids. And we consistently find viral proteins, like key oncoproteins called E5 and E7, within those tumor cells. They're thought to drive the cell growth.
So, case closed. BPV causes sarcoids.
Well, that's where it gets, fascinating and complicated.
Okay.
Because BPV1 DNA, it's also found in the skin and even the blood of perfectly healthy horses. Horses without any sarcoids.
Oh, right. So just finding the DNA doesn't mean the horse has a sarcoid.
Exactly. And another thing, you don't typically find actual infectious virus particles, virions, within the sarcoids themselves.
Huh.
And if you try to experimentally infect horses with BPV, it doesn't reliably cause persistent sarcoids. Sometimes you get temporary lesions, but not always the chronic disease.
So BPV is there, it's involved, but it's not the whole story. Maybe it needs other things to kick it off.
Precisely. It suggests a more complex picture. BPV is necessary, it seems, but not sufficient on its own.
So what are these other factors? Environmental triggers.
Yes, environmental factors seem absolutely key. We sometimes see these epizootic outbreaks like clusters of cases.
And flies are often blamed, aren't they?
Strongly implicated, yes. They're thought to act as mechanical vectors.
Like little couriers for the virus.
Kind of, yeah. Studies have found identical BPV1 DNA in sarcoids on horses and in flies caught in the same area. This really points to flies spreading it between horses, even if the horses don't have direct contact.
Are there other ways it could spread?
Direct contact with a wound is possible. And maybe indirect transmission via fomites, things like contaminated tack, grooming tools, stable equipment, that's suspected too.
And what about trauma? Does injuring the skin play a role?
A huge role. Wounds are very common sites for sarcoids to first appear.
Right.
And if a horse already has a wound, sometimes it just doesn't heal properly, or it can actually transform into a sarcoid. And crucially, any trauma, even a minor knock, or importantly, a biopsy.
A biopsy.
Yes. Even a diagnostic biopsy can sometimes trigger a very rapid aggressive growth spurt in a previously quiet, mild lesion. It can make things much worse quickly.
Wow. Okay, so pulling all that together, what's the big picture on how these things actually start?
The current understanding is that sarcoids likely result from this complex interplay. You need the bovine papillomavirus, yes, but you also need the right genetic background in the horse, that susceptibility we talked about. And then you need some kind of environmental trigger, often trauma, maybe facilitated by vectors like flies.
So it's like a perfect storm of factors.
Exactly. It's
Right.
truly multifactorial, not just a simple infection.
That complexity definitely continues when we look at the many faces of sarcoids. Identifying them must be tough given they can look so different.
It's a major challenge, absolutely. Their appearance varies so widely that diagnosing them accurately just by looking, it's really difficult. One study found vets got it wrong almost a third of the time, 31% error rate.
A third. That's high.
It is. They can mimic so many other skin conditions. Ringworm, proud flesh, other tumors, even just simple rub marks sometimes. Relying just on what you see is risky.
So how many main types are there?
Generally, we classify them into about 5 or 6 main forms, though often you see mixed types, combinations of forms on the same horse, or even within the same lesion.
Let's start with the occult form. That sounds hidden. Is it the earliest type?
Yes, often the earliest, most subtle. They look like flat, maybe roughly circular patches where the hair is missing or looks different, wrong texture, wrong color, sometimes grayish, scaly.
Where do you usually find these?
Often in relatively hairless areas, around the mouth, the eyes, inner thighs, neck maybe. Rarely on the lower legs. You might feel tiny sort of pea-sized nodules under the skin too.
And how do they behave? Do they just stay like that?
They can stay static, unchanged for years. But here's the kicker. They have the potential to suddenly, dramatically transform into a much more aggressive form, often a fibroblastic type.
And that's often triggered by
Trauma. A knock, a bump, sometimes even just rubbing from tack. It makes them really tricky to distinguish from things like simple rub marks or ringworm or alopecia areata or even autoimmune conditions like pemphigus.
Okay. Then there's the verrucous type, warty.
Exactly. Verrucous means warty. These look like gray, scaly, cauliflower-like growths. They genuinely resemble warts or papillomas. Often they have a sort of occult halo of hair loss or skin change or around the main warty bit.
Where do these pop up?
Common around the head, face, ears, also the groin area, sheath, under the tail. Again, relatively rare on the lower legs or coronary band.
And their behavior.
They tend to grow moderately, but just like the occult ones, they're prone to sudden aggressive transformation, especially if disturbed. You could mistake them for ringworm again, or maybe keloids, or just excessive scar tissue.
Next up, nodular sarcoids. These sound like lumps.
They are. Firm, well-defined lumps or masses, usually roundish, located in the dermis or even deeper under the skin. They can vary a lot in size, from maybe half a centimeter, like a small pea, up to 20 centimeters or even more. Huge sometimes.
Wow.
Yeah. The skin over the top might be normal and loose, or it could be thin, shiny, and stuck to the nodule itself.
Any preferred locations?
Yes, common sites include the groin, the prepuce or sheath area in males, and especially around the eyes, the eyelids are a very common spot for nodular sarcoids.
And their growth pattern?
Usually moderate growth, they can sit there quite stable for years even before suddenly deciding to change or grow rapidly. If they get damaged, maybe bumped or scratched, they can ulcerate and bleed.
Okay, and then the fibroblastic type. You mentioned this one can be particularly aggressive.
Yes, this is often considered the most aggressive clinical form. They look fleshy, very vascular, lots of blood vessels. They frequently resemble what horse owners call proud flesh, or technically exuberant granulation tissue.
Right, that uncontrolled healing tissue you see in wounds sometimes.
Exactly like that, but it's actually tumor tissue. They're typically ulcerated on the surface, often weeping or bleeding easily. They can grow outwards on a stalk that's pedunculated, or they can be broadly invasive, spreading sideways and downwards into the surrounding tissue.
Where do you see these most often?
Very common on the lower limbs, especially at the site of a previous wound. Also groin, eyelids, places where skin gets damaged. And they show really aggressive local invasion. They just destroy the tissue around them.
And you said mixed sarcoids are common too.
Very common. Just a combination of two or more of those types we just discussed. You might have a nodule with a warty surface or a fibroblastic area developing within an occult patch.
Is there a malevolent type as well? That sounds serious.
Yes, malevolent sarcoids. Thankfully, these are rare, but they represent the absolute most aggressive, highly invasive form. They spread extensively and rapidly, infiltrating widely through the skin, under the skin, and sometimes along lymphatic vessels.
But still no metastasis to internal organs.
Correct. Even the malevolent form, despite its aggressive local spread, still doesn't typically metastasize to distant sites like the lungs or liver. That distinction remains.
It's really striking, though, isn't it? How those seemingly quieter forms, the occult, the verrucous, the nodular, have this built-in instability.
It is. That ability to just suddenly, seemingly out of nowhere, transform into a rapidly growing, often fibroblastic tumor. It's a key feature.
And often triggered by trauma. It just hammers home why getting an early, accurate diagnosis and then managing them very carefully is so critical.
It does sound a bit like a ticking time bomb.
That's not a bad analogy, unfortunately.
Okay, this leads us nicely into the diagnostic journey, beyond just looking, because clearly, as you said, just looking isn't enough.
Absolutely not. The first step is always a thorough clinical examination, looking closely, feeling the lesion, assessing the surrounding skin. But given how much they vary and how many other things they can look like, that visual exam is just insufficient for a definitive diagnosis.
So relying on what you see, or maybe what Dr. Google says, is pretty risky. Very risky. It can lead to delays, which means the sarcoid might get bigger, more invasive, harder, and more expensive to treat effectively down the track.
So what is the definitive method? The gold standard?
The gold standard remains a skin biopsy followed by histopathology. That means taking a small tissue sample and sending it to a lab where a pathologist examines it under a microscope.
And what are they looking for specifically?
They look for characteristic microscopic features, things like hyperkeratosis, which is thickening of the outer skin layer. Elongated REIT pegs these finger-like projections of the epidermis dipping down. And crucially, the pattern of the dermal fibroblasts, those connective tissue cells. In sarcoids, they often arrange themselves in this very distinctive picket fencing pattern.
Picket fencing.
Yeah, the cells line up in these parallel rows, kind of neat and orderly, almost like a miniature fence under the microscope. It's quite characteristic when you see it.
Okay, so biopsy is the best way to be sure. But you mentioned earlier there's a catch with biopsies in sarcoids.
Yes, there is a significant catch, and it's a real dilemma sometimes.
What's the risk?
The risk is that the very act of taking the biopsy can trigger that sudden aggressive worsening we talked about. It can make the sarcoid flare up, change its nature, become much more aggressive. We call this iatrogenic worsening, meaning it's caused by the medical intervention itself.
Wow. So the thing you do to diagnose it might make it worse.
Potentially, yes. That's why vets are often quite cautious about biopsying suspected sarcoids. They might avoid it unless the diagnosis is really uncertain, and they're prepared to start immediate aggressive treatment right after the biopsy if it confirms sarcoid.
Why does that happen? Any idea?
The hypothesis is that maybe incompletely removing or disturbing the cells during the biopsy activates latent BPV virus within the lesion, sort of waking it up and stimulating that accelerated growth. But it's not fully understood.
That's a major consideration.
Yeah.
So given that risk, what about less invasive options like molecular tests, PCR for BPV DNA?
PCR is definitely an option. It's highly sensitive for detecting the BPV DNA.
So if it's positive, that confirms it's a sarcoid.
Not necessarily on its own. A positive PCR result certainly supports a clinical suspicion of sarcoid. But remember, we can find BPV DNA in healthy horses too, and sometimes even in other types of tumors.
Oh, right.
So, while PCR confirms the virus is present, which is helpful information, it doesn't definitively diagnose the lesion as a sarcoid or tell you how it's likely to behave. It confirms the viral association, but not the tumor's nature or clinical significance by itself.
Okay, that's a really critical distinction. Are there more advanced techniques emerging that could help predict behavior, not just presence?
Yes, definitely. Research is moving in that direction. For example, immunohistochemistry, or IHC, can be used. It uses antibodies to stain specific proteins in the tissue, and it can help confirm the myofibroblastic origin of the tumor cells, fitting with sarcoid.
What about biomarkers, things that might predict recurrence?
That's a really active area. Researchers are looking at things like methylation patterns in the DNA. Changes in how genes are methylated might give clues about aggressiveness or recurrence risk, and could potentially lead to better diagnostic tools or even treatment targets.
That sounds promising. Anything else? I think I saw something about mitotic count.
Yes, mitotic count, or MC. That's basically counting the number of cells actively dividing within a specific area of the tumor under the microscope. A recent study found a significant association between higher mitotic count specifically, 20 or more dividing cells per 2.37 square millimeters, and a higher likelihood of the sarcoid recurring after treatment.
So if that holds up, it could be a really useful prognostic marker.
Exactly. If it's validated in more studies, MC could become a crucial tool to help us assess how aggressive a particular sarcoid is and predicts its chances of coming back, allowing us to tailor treatment intensity, perhaps.
So stepping back a bit, how are these advanced techniques changing the game? What's the bigger picture?
Well, the hope is that these tools will give us much deeper insights into not just what the tumor is, but how it's likely to behave. The goal is to move beyond just diagnosis towards prognosis, towards predicting behavior, so we can choose more targeted, more proactive treatments. It's a step towards more personalized medicine in equine oncology.
Right. Okay, let's shift gears now and talk about treatment strategies. A multimodal battle plan. Because the first thing you realize reading about sarcoids is there's no magic bullet, is there?
Absolutely not. There is currently no single universally effective therapy that works for all sarcoids all the time. Treatment has to be highly individualized.
What factors go into deciding the best approach?
It depends on so many things. The type of sarcoid, is it occult, nodular, fibroblastic? Where is
Yeah.
it located? Near an eye? On a leg? How aggressive does it seem? Then there's the clinician's own experience and preferences, what they're comfortable with, and client factors are huge. Owner compliance, what they can afford, what facilities are available nearby.
And the key principle seems to be act early.
Definitely. Early diagnosis and prompt treatment generally give the best chance of success. Smaller, less advanced sarcoids are usually much easier to manage than large, invasive, or recurrent ones.
And often, combining treatments is better than just one.
Yes, multimodal approaches using 2 or more different strategies together or in sequence often yield higher success rates and lower recurrence rates compared to single therapies alone.
Okay, let's break down the options. Surgical interventions first. What about just cutting it out with a scalpel? Conventional surgery.
Conventional surgical excision. While the reported complete regression rates vary wildly, somewhere between maybe 18 and 82%.
That's a huge range. What's the big downside?
The huge downside is recurrence. Most studies show that a majority of sarcoids removed this way recur, often within just 6 months. And frequently, the recurrence is more rapid and more aggressive than the original tumor.
Why is that? Is it hard to get it all out?
Incomplete excision, leaving microscopic tumor cells behind at the edges, is thought to be a major factor. These cells then just regrow, often with a vengeance.
Okay, so conventional surgery alone isn't great. What about fancier surgical techniques? Electrosurgery.
Electrosurgical excision uses electrical current to cut and also to cauterize or seal blood vessels as it goes. It generally has higher success rates, maybe 75 to nearly 87% in some reports. One study noted 87% success with no recurrence over 6 months.
Benefits.
Less bleeding during surgery, potentially less pain afterwards. It might also help destroy tumor cells at the margins better than a cold scalpel.
Yeah, and laser surgery, CO2 or diode lasers.
Laser excision also offers good results, maybe 60 to 89% success. Like electrosurgery, it minimizes bleeding and might reduce post-op pain and infection risk. it allows for very precise removal.
Any drawbacks to laser?
Some studies suggest recurrence might be a bit higher for certain types, like verrucous lesions or for sarcoids on the head and neck compared to other locations. And of course, laser equipment is expensive and requires specific training.
So, summing up surgery, what's the takeaway?
Surgery, in some form, is often a cornerstone of treatment. But the really high recurrence rate, especially with just simple scalpel excision, means it's often best performed using advanced techniques like electro or laser surgery. And crucially, it's often most successful when used as part of a multimodal plan, combined with other therapies to tackle any remaining cells.
Right. Okay, what about cryotherapy? Freezing the tumor.
Cryotherapy uses liquid nitrogen, which is incredibly cold, minus 196 degrees Celsius. It's applied using a spray or a metal probe directly onto the sarcoid. Usually, they do several freeze-thaw cycles in one session.
How does that work?
The efficacy is extremely variable. Reports range from as low as 9% success up to 100% in some specific cases.
Wow, that's all over the map. Any major issues?
Yes. Recurrence rates can still be quite high, maybe 25 to 60%, especially for sarcoids around the eyes. And more worryingly, there have been reports of severe complications,
Like what?
like actually triggering accelerated growth of fibroblastic sarcoids, causing severe tissue damage, leading to things like septic arthritis if near a joint, and in some rare, unfortunate cases, even necessitating euthanasia.
Oof. So not necessarily a safe bet.
No, it's not considered a consistently reliable or always safe standalone treatment, especially for more aggressive types or sensitive locations.
Okay. Moving on to radiotherapy, or radiation treatment. This sounds more high-tech and perhaps more effective.
Radiotherapy is often highly effective, yes. For certain challenging cases, particularly around the eyes or those that have failed other treatments, it's considered by many specialists to be a gold standard approach.
How is it delivered? I've heard of brachytherapy.
Brachytherapy is one method. It involves surgically implanting radioactive sources like tiny beads or wires or ribbons containing isotopes like iridium-192 directly into or right next to the tumor. This delivers a very high localized dose of radiation.
And the success rate?
Very good, often 74 to 100% success reported, especially for those difficult periocular sarcoids around the eye.
What about external beam radiation therapy, EBRT?
EBRT is another, perhaps more modern approach. It uses a machine, similar to those used in human cancer centers, called a linear accelerator, to direct high-energy radiation beams from outside the body precisely at the tumor.
What kind of cases is it used for?
It's particularly useful for tumors on the head and limbs, maybe larger tumors, or those resistant to other therapies. Often, they'll surgically remove the bulk of the tumor, first debulking, and then use EBRT to target any remaining microscopic disease.
Any key advantages to EBRT?
A big one is that the horse itself is not radioactive during or after the treatment sessions. This means they can often be treated as outpatients, go home between sessions, less isolation needed compared to some brachytherapy implants. It's generally well tolerated too. Modern systems often integrate CT scans for incredibly precise targeting.
Sounds great. Downsides?
It usually requires multiple short sessions, and each session typically needs general anesthesia, which carries its own small risks. It's also very expensive, and the availability of equine radiation facilities is still quite limited.
Still, it seems like a major advancement, particularly for difficult cases. That ability for outpatient care must make a big difference.
It absolutely does. It represents a real shift towards more sophisticated, targeted cancer care for horses, improving outcomes and quality of life.
Okay, let's talk chemotherapy now. Using drugs to kill the tumor cells, but focusing on targeted delivery, right?
Exactly. The goal is usually to get the drug directly into the sarcoid, rather than giving it systemically where it could cause side effects elsewhere. Cisplatin is a common one,
How is that used?
often given as intralesional injections directly into the tumor. Success rates vary, maybe 33 to 78% initially, but some studies show 80 to 90% resolution looking out 4 years.
I read about biodegradable beads too.
Yes, that's a really interesting delivery method. Tiny biodegradable beads impregnated with cisplatin are implanted surgically throughout the tumor. They slowly release the drug over several weeks. One study showed a remarkable 91% cure rate with these beads.
91%. That's fantastic.
It is. And when combined with surgical debulking first, the success rates with cisplatin, whether injected or beads, can approach 98% in some reports.
Wow. What about electrochemotherapy, ECT?
ECT is clever. You inject a chemotherapy drug, often cisplatin or sometimes bleomycin, into the tumor. Then you apply short, controlled electrical pulses to the area using special electrodes.
What do the electrical pulses do?
They temporarily make the cell membranes much more permeable, sort of opening tiny pores. This dramatically increases the amount of chemotherapy drug that gets inside the tumor cells, potentially hundreds or thousands of times more drug uptake.
Does that boost effectiveness?
Significantly. Success rates with ECT are often reported as very high, up to 93% or even better in some studies, for complete resolution. It's become a really valuable tool.
Are there other chemo drugs used? 5-FU?
Yes, 5-fluorouracil or 5-FU. It can be injected into the tumor with maybe around 61% resolution reported up to 3 years. It's also available as a topical cream.
How well does the cream work?
Less impressive generally, maybe around 35% success. It can be useful for very superficial flat adult or verrucous types, but often causes significant local inflammation and irritation. Needs careful management.
Any others worth mentioning?
Yeah, various others have been tried. Mitomycin C eye drops for certain periocular lesions. Intralesional bleomycin, a combination of anthiomoline and vincristine, has shown some promise. And photodynamic therapy, where a light-sensitizing drug is given and then activated by a specific wavelength of light directed at the tumor.
So, looking at all these chemo approaches, what's the common theme?
The clear trend, as you said, is localized and enhanced delivery, trying to get maximum drug concentration right where it's needed in the tumor to boost effectiveness and minimize side effects to the rest of the horse.
Makes sense. Now, a really exciting area, immunotherapy. Harnessing the horse's own immune system to fight the sarcoid. BCG was used historically.
Yes, Bacillus calmette-ingerin, or BCG, which is actually a weakened strain of the bacterium that causes tuberculosis in cattle. It was one of the first immunotherapies used for sarcoids, injected directly into the lesion.
How effective was it?
Quite effective for sarcoids around the eye, maybe 83 to 100% success reported there, but much less effective elsewhere, maybe only 50% success. And recurrence was still an issue, 17 to 20%.
Were there safety concerns?
Yes, significant ones. Severe adverse reactions were reported, including, unfortunately, occasional deaths from anaphylactic shock, severe local reactions, and even things like septic arthritis. It was quite unpredictable.
Okay, so maybe not the best option now. Is immunocytin equine better?
Immunocytin is a more refined, modern product derived from a different type of mycobacterium, Mycobacterium cell wall fraction. It's specifically licensed for equine sarcoids in the U.S. and Canada.
Advantages over BCG.
It's generally considered more predictable, with fewer severe systemic side effects. It seems to have broader applicability to different sarcoid types and locations, and it's often more economical than some other advanced therapies. It can still cause quite dramatic local swelling and inflammation as the immune system kicks in, but overall it's seen as a safer, more reliable mycobacterial immunotherapy.
Okay, now this next one sounds potentially revolutionary. Viral vectors. Specifically something called del-NS. The sources use words like sensational success.
Yes, this is a really cutting-edge area, and the initial results have been incredibly promising. Certain modified viral vectors, like one based on an ORF virus called del-NS, are being investigated.
How does it work?
It's injected directly into one or a few of the sarcoid lesions. What's remarkable is that it seems to trigger a very strong systemic immune response against the sarcoid cells and the underlying BPV.
Systemic, meaning it affects lesions that weren't even injected.
Exactly. Studies have shown complete and apparently permanent elimination of all sarcoids on the horse, including lesions that were never directly injected. This strongly indicates it's activating the horse's immune system throughout the body.
And does it get rid of the BPV too?
Yes, reports suggest it also eliminates the underlying papillomavirus. The proposed mechanism involves inducing a strong interferon response. Interferons are key immune signaling molecules, and activating important immune cells like cytotoxic T lymphocytes and natural killer cells, which then target and destroy the infected tumor cells.
That sounds incredible, like teaching the horse's own body to cure itself.
That's essentially the idea. It's very exciting, still relatively new. Availability might be limited, but the potential is huge.
What about autologous vaccines, made from the horse's own tumor?
Autologous vaccines involve surgically removing some sarcoid tissue, processing it in a lab to create a vaccine specific to that horse, and then injecting it back into the horse, usually intramuscularly, over several weeks.
Do they work?
They show some efficacy, maybe around 69% resolution reported in some studies, but the downside is a fairly high recurrence rate afterwards, perhaps 40 to 50%. So mixed results overall.
So looking at immunotherapy overall, especially these viral vectors, is this the future?
It certainly feels like a very promising direction. The potential for systemic control, treating multiple lesions at once by activating the horse's own defenses, is incredibly appealing. It could truly revolutionize how we manage sarcoids long term, especially in horses with many lesions. Very exciting research. But while we're talking treatments, we absolutely must include a warning about unproven stuff.
Right, because you see a lot of things marketed online or by word of mouth, don't you? Things like Thuja cream, some people mention toothpaste, various herbal concoctions, supplements promising miracle cures, Sark Secret, Sark X, names like that.
Exactly. And the crucial point here is that none of these commonly touted alternative remedies have any rigorous scientific evidence to prove they actually work on equine sarcoids. None.
And they might not just be ineffective, they could be harmful.
They absolutely could be. They might irritate the sarcoid and make it worse, or perhaps more commonly, using them just delays owners from seeking proven veterinary treatment. And during that delay, the sarcoid can grow larger, become more invasive, maybe spread, making it much harder and more costly to treat successfully when they finally do see a vet.
So why do some people think these things work? You hear anecdotes.
There are a couple of main reasons for perceived success. One is simply misdiagnosis. Someone treats a lump that wasn't actually a sarcoid, maybe it was a simple wart or a patch of ringworm, and it goes away on its own, and they attribute it to the remedy they used.
Makes sense.
The other big factor is the phenomenon of spontaneous regression. Sarcoids can sometimes just disappear on their own without any treatment at all.
Really? How often does that happen?
The reported rates vary hugely, from less than 1% in some studies to as high as maybe 48% in others, depending on the type of sarcoid in the population studied. So if a horse happens to be using an unproven remedy when its sarcoid spontaneously regresses, it's easy to mistakenly believe the remedy caused the cure.
That's a really important point. Correlation isn't causation.
Exactly. Stick to treatments recommended by your veterinarian, treatments that have actual evidence behind them.
Okay, vital warning. Now, let's talk about the long game, prognosis and managing recurrence. Because unfortunately, even with the best treatments, recurrence is a major headache with sarcoids.
It really is the defining challenge. High recurrence rates are the norm, not the exception. We're talking maybe 18% on the low end, up to 64%, or even higher in some studies, depending on the treatment used, the type of sarcoid, and how long they followed the horses. And they can recur years after they seemed completely gone.
Years later, wow.
Yes, it's a persistent condition.
Are there factors that help predict whether a specific sarcoid is likely to come back?
We're still figuring that out definitively. The clinical subtype might play a role. Some studies suggest the fibroblastic type is more prone to recurrence, but the data isn't always strong due to small sample sizes sometimes.
And that mitotic count we discussed earlier, the MCO20.
That looks like a very promising potential predictor, yes. If that link between high mitotic activity and recurrence is confirmed in larger studies, it could be really valuable for prognosis.
What about how completely the surgeon removed it? Does leaving cells behind guarantee recurrence?
You'd think so, and anecdotally, vets strongly believe incomplete excision is a major cause of recurrence. But surprisingly, the scientific studies trying to prove a direct statistical link haven't always consistently confirmed it. It's complex.
And that spontaneous regression factor muddies the waters too, right? Hard to know if treatment worked or if it would have gone anyway.
Exactly. It makes evaluating true treatment success rates quite difficult. And we also know that any trauma or interference with a sarcoid, or even just a suspicious skin area, can trigger aggressive growth or multiplication. It's like poking a sleeping bear sometimes.
So for horse owners, managing sarcoids is really a long-term commitment. What does ongoing management look like?
Vigilance is key. Regular reevaluation is paramount. This doesn't just mean checking the spot where the sarcoid was. It means thorough reexaminations of the horse's entire skin surface regularly for years after treatment, because new ones can pop up elsewhere or tiny ones can start growing.
And owner education must be critical too.
Absolutely. Owners need to understand how variable sarcoids are, what the early signs of recurrence look like, and the absolute importance of avoiding any trauma, no picking, no scratching, no harsh chemicals on any suspicious lesion, and they need to report any changes to their vet promptly. Don't wait and see.
What if it does recur? You're the square one.
Often, yes. Management plans need to be flexible. Recurrence might mean repeating the same treatment if it worked well initially, or, more often, switching to a different strategy, maybe a more aggressive multimodal approach.
Is there ever a point where trying to cure it isn't the main goal anymore?
Yes, sadly, for some cases, maybe very extensive sarcoids, or those in really difficult locations like around the eye where aggressive treatment risks function, or ones that just keep recurring despite multiple treatments, the goal might shift towards palliative care, managing comfort, controlling pain, preventing secondary infections, rather than constantly pursuing a cure that might be elusive. Focus on quality of life.
And you mentioned environmental control earlier. Fly control.
Yes, while the hard scientific proof is maybe lacking, anecdotally, many vets feel that rigorous fly control using fly sheets, masks, repellents, managing manure, and just good general hygiene practices seem to help reduce the development of new sarcoid lesions, particularly in horses that seem prone to them. Worth doing anyway.
Okay, so we've really taken a deep dive today into equine sarcoids, a truly fascinating, but also, let's be honest, incredibly frustrating condition for everyone involved.
Absolutely. Despite being non-metastatic, which is good news, their aggressive local behavior, the sheer variety of forms they take, and that stubborn tendency to recur makes them a massive challenge for horse owners and for us vets.
We've unpacked the complex causes that mix of virus, genetics, and environment. We've looked at the diagnostic challenges, including that tricky biopsy risk.
And we've surveyed the huge range of treatments, from traditional methods like surgery to more precise things like radiation, targeted chemo, and those really exciting developments in immunotherapy like the viral vectors.
But that high recurrence rate just keeps coming up. It really underlines that managing sarcoids is a long game. It requires that constant vigilance, ongoing monitoring, and being ready to adapt the strategy.
It's clear we've learned a lot, but there's still so much more we need to understand to really conquer this condition.
And that leads perfectly into our final provocative thought for you, our listeners. If the future really does lie in, you know, harnessing the horse's own immune system, maybe using these cutting-edge molecular techniques to predict tumor behavior, what's it actually going to take? What's the missing piece needed to finally develop a widely available, truly preventative measure, or maybe that universally reliable cure for this persistent equine ailment?
And maybe, what other insights from human cancer research, human oncology could still be applied? What breakthroughs there might help revolutionize how we treat sarcoids, and maybe other equine cancers too? Something to think about.